You know, mental health nursing has got to be one of the most demanding fields in all of healthcare. It takes this incredible mix of clinical smarts, legal know-how, and just deep, deep empathy. So when a crisis hits, how do you make the right call? Well, that's what we're going to break down today.
Just think about it for a second. An agitated patient, a suicidal thought, a tricky legal dilemma. You've got seconds to figure out what to do first. You have to assess the risk, make sure everyone is safe, navigate the patient's rights, and somehow communicate perfectly. The pressure is just immense, and the stakes? They couldn't be higher.
So here's the secret. It's not about having some magic script memorized for every single scenario. That's impossible. It's about having a solid, reliable mental model, a critical decision framework that guides you when things get really tough. And that is exactly what we're going to build together.
Okay, let's get right into it. We're going to build this framework piece by piece, starting with the absolute, non-negotiable foundation of every single decision you're ever going to make in this field.
This is it. This is the big one. Before you do anything else, before you de-escalate, before you educate, before you advocate, you have to ensure safety. And that means learning to instantly tell the difference between something that's concerning and something that is actively life-threatening.
Let's look at a clear example. A client with mild Alzheimer's misplacing their keys. Well, that's an expected part of the condition. It's something to note for sure, but it's not a 5-alarm fire. But a client on lithium who suddenly has decreased urine output, that is a massive red flag. We're talking potential lithium toxicity, which is a life-threatening medical emergency that needs action right now.
Here's another one that really drives the point home. A client believing others are deceiving her is a classic symptom of paranoid personality disorder. That's a psychiatric priority, absolutely. But hyperpyrexia, an extremely high fever, could be a sign of serotonin syndrome, which can kill you. The takeaway is simple. The physiological crisis, the body screaming for help, always takes priority.
So this all boils down to knowing these absolute, non-negotiable red flags. Things like command hallucinations, telling someone to hurt themselves, any current suicidal thoughts, the constant physical activity you see in mania that can lead to total exhaustion, the signs of alcohol withdrawal, we're talking seizures, skyrocketing blood pressure, or a dementia patient who is wandering. These are never wait-and-see situations. These demand immediate intervention.
And you know, this whole safety-first idea, it's the exact same logic we use for de-escalation. You don't just jump to the most extreme measure, you climb a ladder, always starting with what's least restrictive. First, get them to a quiet space. Then, use short, simple sentences. If that's not enough, you can offer medication and set firm limits. And this part is crucial. You have to document every single one of those steps before you could ever even consider using restraints.
Okay, so once immediate safety is addressed, you find yourself on what I like to call the ethical tightrope. This is that tricky place where you have to balance patient confidentiality, their individual rights, and your own legal duties.
A really big concept here is the duty to warn. Now, we all know patient confidentiality is sacred, but it isn't absolute. If a patient makes a credible threat against a specific person, your legal duty actually shifts. It moves from protecting the patient's privacy to protecting that potential victim.
So how do you handle this in the real world? When somebody, a family member, anyone, asks you about a patient, this phrase right here is your shield. I cannot discuss the care of anyone who might be hospitalized. It's polite, it's professional, and it's perfectly HIPAA compliant because you're not even confirming the person is a patient. It's a clear, firm boundary. Navigating patient rights also means you have to understand their limits. A patient has the absolute right to refuse treatment, like group therapy, and our job is to respect that choice. At the same time, you have to know the scope of your own role. For example, when you sign an ECT consent form as a witness, you are not saying the patient is informed. You are only saying one thing. I saw this person sign this piece of paper. That's a really critical distinction.
And really, all of this, it all points to one of your most important jobs, being a patient advocate. It's not just about giving care, it's about making sure the patient's voice is heard. A perfect example is going to the provider and saying, "My client wants to refuse this treatment." You're bridging that communication gap and making sure their autonomy is honored.
All right, finally, let's talk about one of the most powerful tools you have in your entire kit. It's something that supports everything else we've just discussed: your words. Therapeutic communication, it's not a soft skill, it is a clinical intervention.
Just think about that. The way you communicate can directly change how a patient feels and how willing they are to work with you on their own care. Your words can either build trust or they can completely tear it down.
Let's take a really serious example: suicidal ideation. If a client says they feel hopeless, a non-therapeutic response is to just try and medicate the feeling away. That can feel really dismissive. The therapeutic and much safer response is to ask the direct question: have you thought about harming yourself? You have to ask. It opens the door to a real safety assessment and shows them you're taking their pain seriously.
It's the same exact thing with grief. Telling someone to just move on or stop dwelling on it is, well, it's just not helpful. But offering a concrete resource, like a support group, that gives them a tangible step forward and validates their struggle without judging it.
And these techniques are real, practical interventions. For a client with dementia, you always approach from the front so you don't startle them. You can use symbols to help them find their things. For someone who's agitated, just asking them to describe what they're feeling can help them process it. If someone is struggling with coping, you can ask about their support system. And for stress, you can actually teach them cognitive reframing. These are all specific, therapeutic actions you can take.
So, let's bring this all home. We've got our 3 big pillars, right? Safety first, the ethical tightrope, and words as interventions. But what is it that holds all of that up?
It all comes back to this one central insight. This whole framework is built on your ability to look at a complex situation, figure out what the most urgent need is, and it's almost always safety, and then act with purpose. Look, the framework we've been talking about, that's your toolkit. It's absolutely essential. But a tool is useless without the right foundation. And that foundation is your commitment to always keep learning, and your genuine compassion for the people you care for.
And you know, maybe in the end, it all just boils down to this one simple, powerful promise. Beyond all the protocols and frameworks and legal definitions, this is the heart of it all: to truly, deeply pay attention to another person's pain.
Which leaves us with one last big question to chew on. We can learn the frameworks, we can memorize the red flags, but in our day-to-day practice, how do we actively get better at mastering that one tool that makes all the others work? How do we master compassion? That's the real challenge and the true art of nursing.